have the honor to start and to have 5 minutes in introduction. Then Dr. Andreas Rees and Dr. Norman Daniels will present ethical priority setting for a progressive realization of universal health coverage. Then we will have 6 countries, Mexico, Bolivia, Cuba, Sri Lanka, Estonia, Sweden experience, and then we will have a general discussion. Thank you very much. And I'd like to have my first slide, please. My main purpose is to say universal health coverage is a direction, not a destination. And many organizations, and especially World Health Organization, work on this subject, and I will present some ideas, but Andreas Rees will insist on it. So as you know, the health expenditure is growing, and the problem is this is mean, but in some countries, citizens are paying from their pocket to be treated and to have the right to be treated in the hospitals or private clinics. This, you know, it's in French, I'm sorry, some slides are in French, $8 trillion in 2008, and in 2010 it's $6.5 trillion for the health, and this is growing. It was 9.7 of the national income, and now it's 10.4. So to achieve universal health coverage, countries must advance at least 3 dimensions, and everybody will be back to this 3 dimensions. Expand priority service, include more people, and reduce, this is a real problem in my country, for example, out-of-pocket payments. And everybody is familiar with this schema, the 3 dimensions to consider. Andreas will be back on it. The question is, expanding priority service, and critical choice is which service to expand first, including more people, whom to include first, reducing out-of-pocket payments, how to shift from out-of-pocket payments toward prepayment. This is, I think, the 3 main subject, and it is, of course, WHO in the report that asked for these 3 main subjects. From my point of view, we can imagine that the first level is prevention technology like vaccine, health promotion, large coverage, low-cost intervention, and this should be the priority for all the countries because it's the basement of all the health system. But universal health coverage should be built on solid foundation, and as all the declaration said, there is right of health. The right of health, the right to health service is a human right. But it needs a prerequisite, set the vision, clear commitment to acts, translate into measurable targets, daring to make choice and be accountable for it. As I said, universal health coverage is a direction, not a destination. And no country, even the rich country, fully achieved this coverage objective. But all countries want to reduce the gap between need and utilization, improve quality, improve financial protection. Often, it translates into reducing explicit inequalities in benefits and funding per capita between groups. Relatedly, universal health coverage as a means to the end of having fair societies. There is no standard package for health service action to progress towards universal health coverage. Every country already has a health system. This is the starting point for any reform. And this picture, I took it in the desert of my country. these nomads, you know, it's 5 o'clock in the morning and they are preparing bread. They have nothing, no water, no electricity, and the problem is how to cover them as everybody. Thank you very much. So now we'll give the floor to Andreas Ress to present his talk. Andreas?
It is a great honor and pleasure for me to be able to report to you on one of the recent publications by WHO on ethics and universal health coverage, together with Norman Daniels, who's one of the leaders of this project and one of the pioneers of this area of ethics of priority setting. But first, I would like to thank the local organizers of the summit, Manuel Ruiz de Chavez and his team, who have done a fantastic job in bringing this global summit to new heights. Priority setting in healthcare and universal health coverage is a common concern for many of our member states and also their national ethics committees. Universal health coverage is also one of the top priorities for WHO. While universal health coverage is a relatively recent term, WHO has a long history of promoting the access to healthcare for all. The WHO Constitution of 1946 already stated that health is a universal human right, and I quote, "The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social condition." And on this slide, you see that WHO has, over the course of the last decades, taken many initiatives to promote healthcare for all. For example, in 1978, Alma Ata, and then in 2005, the Commission on Social Determinants of Health, and more recently, promoting primary health care and universal health coverage. But it is not only WHO that is promoting the implementation of universal health coverage. In 2012, WHO's push for implementing UHC received a very strong support by the General Assembly of the United Nations. It adopted a resolution urging governments to move forward towards providing all people with access to affordable quality healthcare services. The resolution also recognized the role of health in achieving international development goals. And moreover, it affirmed WHO's leading role in supporting countries to respond to the challenges of implementing universal health coverage. And this, of course, also includes supporting national ethics committees as they advise their governments. But we should not forget that UHC has a lot of ethical underpinnings. And our Director General, Dr. Margaret Chan, recognized this in a statement last year, and I quote, "I regard universal health coverage as the single most powerful concept that public health has to offer. It operationalizes the highest ethical principles of public health. It is a powerful social equalizer and the ultimate expression of fairness." WHO has received more than requested support from more than 70 countries and advice for UHC. The plan of action of WHO also includes offering guidance on how to move forward in an ethical manner to UHC. This is why WHO established a consultative group on equity and universal health coverage to develop this guidance. This was a very multidisciplinary group, composed of ethicists, economists, and policy experts from different countries. And the drafts of this document were circulated for external review, including to some of the national ethics committees. Now, what exactly do we mean by universal health coverage? Here you see a definition. We mean all people receiving quality health services that meet their needs without being exposed to financial hardship in paying for the services. This is a very broad definition, an inclusive definition. Now, the working group was very clear that we should stay realistic. Given the resource constraints, this does not entail all possibly effective services, but a comprehensive range of key services that is well aligned with other social goals such as environment, transport, and so forth. Hand over.
Thank you. My name is Norman Daniels, and it's a great honor to be here speaking to you. One of the central issues in universal health coverage is how to expand the famous cube that Mohammed showed you a few minutes ago. Expand the blue to fill more of the rest of the cube. There are 3 dimensions that are talked about here. Expanding the range of services, which would be the front to back dimension, reducing the out-of-pocket payments through cost sharing and fees, and extending the numbers of people who are covered. But even if you were to fill this cube, even if we had a full cube, the blue filling everything, and we had universal health care, we should not expect that we've achieved health equity in a system. And that is because there are many determinants of health beyond the health care system itself. Public health and social determinants are key producers of population health and its distribution. So universal health care is an important contributor to health equity, for it insists on equity for everyone whom the society can keep healthy, cannot keep healthy, but it fails in some ways to address the problem of health, the distribution of health that is affected outside of the health sector by the inequalities that exist in a society in the distribution of other determinants of health. So my conclusion from this is that universal health care is a requirement of social justice, but is only part of the social justice that we are concerned with. The document that was produced by this group contains a strategy for prioritizing services. Specifically, there is the goal of dividing services into 3 categories of priority: high, medium, and low. And then looking at the trade-offs that exist between some of the dimensions of the values that are concerned. So we might think that the middle category of benefit maximization is the sole concern of the strategy, but we must compromise benefit maximization by looking at the other values that are concerned as well. So in fairness, the conception of fairness was taken to be focusing on the worst off groups in society. And we could imagine, for example, a long history of inequality between some groups that decision makers in a particular setting want to do in a way that fails to maximize benefits for the society in the aggregate, but is targeted in some ways at improving the fairness or reducing the inequity between a traditionally excluded group and not. Similarly, we could worry that some of the costs of health care that are not addressed by benefit maximization need to be addressed. And so universal health coverage has to also think about the financial risk protection that a system affords. And so there are going to be reasonable disagreements among people about the trade-offs between benefit maximization and on the one hand, and fairness or fair contribution on the other. And this requires some sort of process for making decisions that is fair and has legitimacy and holds people accountable. In any case, the strategy says we should group preventions into high, medium, and low, where green here is the high, yellow the medium, and red the low. And we might think that there's no overlap problem in the cases where there is a clear color that is standing out as a medium. So if one goes to just between 2 and 1.5 on this slide, you have a medium category that has no disagreement about how to categorize it. Nevertheless, there might be some disagreements about how to promote a high-ranking service, say close to 2 in the red domain, compared to something a little below 2 in the yellow domain. And those disagreements are important to address, and even though there are no overlap between them. The main determinant that was used in deciding the grouping was cost effectiveness. And cost effectiveness has come under a lot of criticism. And I think there are two fundamental issues that are normative. And then there's another one that has to do with measurement. The one that has to do with measurement that is not mentioned on this slide is that a lot of the cost effectiveness is really not about costs but about prices, and we know that prices can shift extensively and change the effectiveness, the cost effectiveness ratio that's produced. But there are normative problems. Even if one had a good measurement of costs and cost to decision makers, then still, cost effectiveness ignores the distributive effects of cost effectiveness, and it ignores the financial risk protection that has to be given in a population. So there are going to be reasonable disagreements about how to trade off cost effectiveness against concerns about the distribution of the healthy life years or concerns about the financial risk protection. Next. In addition to that, there's a general problem of whom to cover next. And what the proposal is that we take the worst off groups and hard to reach populations and other relevant groups who are systematically disadvantaged in a society. But there still is a trade-off, because if we are looking at worst off groups, then we may be compromising health benefits, and reasonable people will disagree about how much to make this trade-off. So there is room for discussion and deliberation about how to make those trades and how to identify what falls into the different packages of high, medium, and low.
The third dimension of the cube is about reducing direct payments and out-of-pocket payments. We know from many countries that often even small direct payments are barriers to access, especially for the most vulnerable and the poorest populations. Direct payments are a cause of financial burden, and often enough, they result in catastrophic health expenditures. And Manuel mentioned that also in Mexico, there's a project ongoing specifically on this issue. So the expert group recommended the following: a shift away from out-of-pocket payments and toward mandatory prepayment with a pooling of funds. And when countries are making such a shift, they should seek to first eliminate out-of-pocket payments for high-priority services, and they should also eliminate direct payments for low-income groups and other disadvantaged groups, if that can be done effectively. Sometimes that's not easy. And third, the financial contributions that are required should be made dependent on the ability to pay, and the receipt of services should be made dependent on need.
This approach leads to an identification of some unacceptable trade-offs. And first one I want to mention is giving priority through funding to low as opposed to higher ranking services. So to expand low or medium priority services before there is near universal coverage for high priority services is identified as an unacceptable trade-off. Unfortunately, that is a trade-off that is often made in many countries. A second unacceptable trade-off is to give financial protection for costly services before there are substantial health gains for the population. And this kind of trade-off also is a subject of a lot of disagreement that takes the form of lobbying for particular patients who might get protection from the financial burden at the opportunity cost of providing more useful services to larger parts of the population. The there are two other unacceptable trade-offs that are worth mentioning. That is one very common one, helping well-off patients before worse-off ones. And so expanding the coverage for well-off groups before doing so for worse-off groups when the costs and benefits are not vastly different. So this is something that happens at the in the area where there is a lot of disagreement. And a fourth concern is to first include in the universal coverage scheme only formal workers or those with the ability to pay and not informal workers and the poor, even if such an approach would be easier. I mentioned before that there were significant reasonable disagreements that took place. And so, I wanted to describe some conditions that Jim Sabin and I have proposed. The acronym A for R is accountability for reasonableness, not something that is an easy term to swallow, but it is become widely accepted as a characterization of a fair process in a range of health systems. So one thing it emphasizes is publicity, and this is a focus on the rationales for decisions, not on the decision outcomes only. So there is also a concern that the people involved in the decision making find rationales that form a basis of agreement among them, and therefore that they think rest on relevant considerations. In this context, our view is that stakeholders in the system should have a role in vetting these reasons, and this broadens the deliberation often to include a range of people who may then advocate for particular views which are not understood or accepted by others in the group. And there has to be a deliberation that is responsive to the range of situations that people are talking about. Finally, I say finally because revisability is the last substantive consideration that we need to look at. These decisions that are made have to be revisited on a regular basis and in light of new evidence and arguments. And there ought to be an appeals process because sometimes decisions that advantage a group or the society as a whole don't necessarily advantage individuals, and they have to be examined carefully to make sure that there are no undue burdens imposed on individuals, and that's what an appeals process could do. And finally, the other conditions that I've mentioned, publicity, relevance, and revisability, have to be met, and that is a task of enforceability. Unfortunately, and this is a task for the NECs represented here, is that there has to be training of people to address these problems of priority setting. Many people in bioethics that you represent have a background in either clinical consultations or research ethics, but few have training in population health or population ethics. And that's what's involved in thinking here about priority setting. How does a health system address the health needs of a whole population? There's a need for training people with an interest in bioethics in these issues of priority setting and in the issues about involving or expanding services and covering more people and financing healthcare to avoid out-of-pocket payments. This training plays an important role in providing people who can participate and consult on the fair deliberative process that I'm saying is necessary. And so I think that every country represented by the people in this room has an important role in facilitating the training and implementation of universal health care by helping bioethicists to understand this broader picture about priority setting. So I wanted, on behalf of the group, to thank a range of people who made possible and this report and who participated, and they're listed here. I won't read their names.
Thank you very much. A question, okay. We can take 5 minutes question. Okay, Christiana?
Yep. Thank you very much for this wonderful presentation. And I have just a question as to the concepts underlying these deliberations. And it pertains to the notions of health, well-being, and quality of life. So the WHO has definitions, and I wonder in which relationship they stand to each other. So you have the definition of health, which is health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And you have the definition of quality of life, which is defined as individuals' perceptions of their position in life in the context of the culture and value system where they live, and in relation to their goals, expectations, standards, and concerns. It is a broad-ranging concept incorporating in a complex way a person's physical health, psychological state, level of independence, social relationships, personal beliefs, and relationship to salient features of the environment. So what I want to point out is that on one side, quality of life seems the overarching concept. On the other side, health seems to be the overarching concept. And Norman already referred to the difficult relationship between universal health coverage and social justice. And as it seems here, universal health coverage is social justice. Yeah? So I think we have to elaborate a little bit more on the underlying concepts and to be more precise, perhaps abstaining from formulating ideals, which are wonderful, to having aims to strive for, but which are not feasible in everyday life. And that doesn't depend whether you're in Germany or in Kenya or in Asia or somewhere else. It's not feasible, it's nowhere feasible. Yeah? So which is the relationship between these concepts?
Thank you very much for this excellent question. And you are, of course, right that the WHO definition of health is very broad and very inclusive and has been criticized at many occasions for that. But I think it's really quite revolutionary for the 1940s. And the report Fair Choices that we just presented recognizes that health is very much dependent on the social determinants of health, and that for truly achieving universal health coverage, countries need to also tackle the root causes. That said, it would have been beyond the scope of this report to address this broader issue, and it has been addressed in the report of the Commission of Social Determinants. So this report really focuses very much on the difficult choices that health systems have to make in moving forward towards universal health coverage.
I don't speak with the hat of WHO, and I am one of the critics of the definition that WHO uses for health. So in all honesty, I would have to say that I don't think the definition actually is a appropriate definition for health itself. I think it confuses well-being more generally with health. Nevertheless, I think the distinction that is made about the importance of providing universal access to health care is important despite that definition. And what this report was focused on was the choices people have to make to do that, as Andreas said. So we set aside the debate about the definition of health, and I was able, as a critic of that definition, nevertheless to think there was something useful about focusing on the choices without going to those fundamental questions about health.
Thank you very much. We will move, if you don't mind, to the presentation of our colleague from Mexico, Dr. Gabriel Oshie.
Thank you very much. Good morning, everybody. I want to thank, in first place, Dr. Manuel Ruiz de Chavez for the invitation, for being here this morning. It's a pleasure to be here. Can I have the first one, please? Well, we're going to speak today about the great reform that in the year of 2003, the Mexican Congress approved. This reform in Mexico, creating and establishing the system of social protection and health. This system, what it does, it increases the public funding to guarantee universal health coverage. What does this mean? For all those families that were excluded from traditional social security systems, they can now enroll in the Seguro Popular. That's the way we know it here in Mexico. The traduction is the translation is popular insurance. This is a new public insurance scheme that guarantees access to a comprehensive health care by law. Well, the bioethical principle supports that the healthcare is a social right. So, well, the challenge is to procure competent healthcare that value diversity and promote the protection of original cultures, as well as their involvement and communication in matters pertaining to public health. The universal health coverage in Mexico translates into social protection and health, mainly in the following. In first place, the universal enrollment. This is legal coverage and entitles all Mexicans without Social Security rights to benefit from health services funded by public organized insurance. Number two, the access to a comprehensive health services package. This guarantees a universal healthcare package. The way we designed this health package was using cost effectiveness analysis, and it has been progressively expanded to provide high quality of healthcare coverage and by reducing the payments pocket of each Mexican. Well, the system of social protection and health, or Seguro Popular, is a public insurance program. We now in June we have around 56 million people enrolled in this system. This will equivalent to 50% of all the population here in our country. The benefits offered through Seguro Popular are mainly embodied in two plans. The first one, we call it Cauces. It's a low and medium plan called Universal List of Essential Health Services. And the other plan is called a High Cost Interventions. We call it Fondo de Gastos Catastróficos, or it's a Catastrophic Health Fund. Well, how do we procure the money for this health system? We have three main systems insurance here in Mexico. The first one is the IMSS, or Mexican Social Security Institute. This is where workers, former workers, retired, and families enrolled in Social Security. The other one is ISSSTE. This is where the government workers are enrolled, the teachers, and the Seguro Popular. Mainly the public assurance for Seguro Popular comes from the federal government. Well, how do we provide the financial protection for this population? Well, mainly it's the federal contributions. The family fee is no more, we don't have it anymore because the 98% of our population don't have the economical capacity to pay for it. Can I have the other one? The next one. Well, this is the way we transfer the money to the states. 89% goes to the Cauces. That's the list of essential health services. The 8% expense goes to the catastrophic fund protection for specialized services, high-cost disease, and the 3% budget goes for infrastructure needs. That's to make new hospitals and to get equipment for the hospitals functioning. This is the way we have been working the last 10 years since we started in 2004. We had 5.3 million of Mexicans enrolled. Now we have almost 56 millions. This year we're going to finish with 57.3 millions enrolled in the Seguro Popular. And the number of medications have been increasing. We have here, we started with 142 medications. Now we have 634 medications. The number of interventions has increased almost 3 or 4 times. Here in 2014, we have 285 interventions. Well, what are the components of the Seguro Popular? The Seguro Popular covers 285 primary care interventions and the most illness reported as major hospital discharge. And it includes 634 medicines for attending all those 56 million of Mexicans. And the catastrophic health fund that it's the 8% of the total resources, and it includes 59 medical interventions. This is the catastrophic fund. We can see this is the most expensive illness we have covered by it. It's 59 interventions and 19 diseases. Well, the causes includes 285 healthcare interventions and including the catalog of 634 medicines. We have a health insurance for children under 5 years of age. We call it 21st Century Health Insurance. This includes 140 interventions. Well, this 21st Century Health Insurance is a protection for children under 5 years of age. It covers all the disease in this age group. We have around 5,400,000 children affiliated till December of 2013. Well, we have another program then called Oportunidades. This program, what it does is guarantees a basic package of healthcare training, and provision of food supplements for children from 6 to 59 months of age. We have around 15 million people affiliated until December 2013. Well, what's the role of the National Commission of Bioethics in the universal health coverage? Well, in the program, the sector program for 2013 and 2018, we foster to respect for human rights. We encourage research to following the ethical criteria. We incorporate the bioethical perspective to design the public policies, and we promote observance of international bioethical criteria. Can I have the other one? Well, what are our challenges now in Mexico? We have to increase the plan's serving coverage. This is the gap between Seguro Popular enrolls and Social Security enrolls should be reduced. We have to improve transparency with regard to Seguros Popular sources and the use of funds. There's a concern about the use of funds and the efficiency achieved with the available resources. And the last one is to introduce and to walk to the Universal Health Benefit Plan. Thank you very much.
Thank you very much. Now we'll give the floor to our colleague, Dr. Javier Ernesto Luna from Bolivia.
En principio, saludar a todos los asistentes, particularmente a los miembros del panel, y agradecer a la Organización Mundial de la Salud y a CONBIOÉTICA esta honrosa invitación para participar en el panel, y saludar también al doctor Gabriel Ochía, comisionado de Protección Social en Salud de México. Mi exposición va a ser en español, con proyección de diapositivas en inglés, y voy a procurar atenerme al tiempo establecido de los 10 minutos. Si me pudieran dar la primera diapositiva, por favor. Voy a abordar el tema que lleva por título Institucionalización de la salud. El fenómeno salud-enfermedad es holístico y multifactorial. Esto significa que la solución a sus problemas o la búsqueda de metas como la cobertura universal de salud va más allá de los alcances restringidos al propio sector y sus respectivos estamentos. Por tanto, siendo coherentes con la definición de salud de la Organización Mundial de la Salud, que incorpora entre sus componentes el bienestar social, la cobertura universal en salud que se pretende debe incluir la solución de las causas determinantes de males sociales que provocan enfermedad individual, familiar, social y medioambiental, siendo la pobreza y sus agravantes la más representativa de todas. Caso contrario, las soluciones serán siempre fragmentarias y la cobertura universal de salud seguirá siendo una utopía como hasta el presente. Lo dicho encuentra su confirmación en los siguientes indicadores. 1.200 millones de seres humanos, es decir, más del 17% de la población mundial, vive con menos de $1 al día. El 20% de la población mundial percibe y controla el 80% de la riqueza, mientras el 60% sobrevive con el 7%. El gasto público anual en salud fluctúa entre 20 y más de $6.000 por persona, dependiendo de las realidades que tiene cada país. Para 5.600 millones de habitantes de países de ingresos bajos y medios, más de la mitad del gasto sanitario se cubre con pago directo, es decir, gastos de bolsillo. La pobreza sigue siendo la primera causa de enfermedad, cobrando diariamente la vida de 28.000 niños. De 136 millones de mujeres que darán a luz, 58 millones no recibirán ninguna asistencia durante el parto y puerperio. Esta dramática situación no puede soslayarse, siendo un imperativo ético el involucrarnos en reflexiones y acciones que abarquen no solo la nosología humana conocida por todos, sino también las que llamo nosología social y nosología medioambiental, afectando ambas la seguridad misma del planeta. Sin embargo, lo limitado del tiempo de esta sesión no permite abordar esta problemática, limitándome, por tanto, a un análisis muy específico de la institucionalización de la salud, que significa reconocer el beneficio de la salud como un derecho perfecto, es decir, inalienable e imprescriptible, que debe otorgarse en condiciones de calidad a través de una dinámica regular y sostenida de la organización sanitaria, con políticas, planes y acciones claramente definidos bajo el mandato indefectible de un marco legal encabezado por la Carta Magna de toda nación o Estado. Con esta consistencia, que a nuestro juicio resulta ética y jurídicamente incuestionable, la salud deja de ser un concepto y se convierte en un precepto macropolítico que reclama o debiera reclamar ser prioridad de Estado en todo lugar, tiempo y circunstancia. Debiendo entonces preguntarnos, ¿está la salud institucionalizada? La respuesta, por cierto, no puede ser absoluta e igual entre los países, tanto más si comenzáramos a ejemplificar situaciones de realidades seguramente específicas y por tanto parciales, limitándonos tan solo a decir que la salud para todos, entre comillas, proclamada por primera vez en Alma Ata hace casi, 36 años, está lejos de convertirse en realidad por una diversidad de razones, motivando que la propia doctora Margaret Chan, directora general de la Organización Mundial de la Salud, hubiese dicho en su discurso inaugural: creo que el mundo está más desequilibrado que nunca en materia de salud. Ahora bien, de esa diversidad de razones queremos resaltar algunas. 1. Las constituciones de muchos estados no reconocen o no incorporan el derecho perfecto a la salud como un derecho legal y por tanto exigible. Hablan más de un mandato ético, pero no de un derecho exigible, presentándose además tendencias a disminuir el beneficio de la salud en países avanzados. En segundo lugar, muchos otros estados, si bien lo reconocen constitucionalmente, no lo respetan o lo cubren parcialmente, generando desorientación y falsas expectativas en la población. Es el caso de Bolivia, mi país, con una constitución muy rica en reivindicaciones para la salud, pero que no se cumple. En tercer lugar, el abordaje de la salud sigue siendo sanitarista y curativo, sin asumir que sus determinantes merecen un manejo multisectorial y multidisciplinario, siendo la deficiente organización sanitaria y la ausencia de políticas sostenidas de salud un problema estructural de muchos países, agravado por un manejo discrecional de quienes detentan el poder. En cuarto lugar, temas como la guerra o el crecimiento tecnológico incontrolado provocan un grave desequilibrio de las macroeconomías, determinando un ingente secuestro de recursos financieros en detrimento de los avances sociales, incluida la salud. En quinto lugar, lo dicho se agrava con el alto crecimiento demográfico, la aparición de nuevas enfermedades, la creciente contaminación ambiental, los desastres naturales, la crisis alimentaria y el cambio en los hábitos alimenticios, los conflictos bélicos, el terrorismo, la violencia social, los accidentes de circulación y las limitaciones de acceso a los servicios de salud por una tendencia cada vez más centralista de atención puramente hospitalaria. En función a esto último, planteamos modificar el modelo sanitario centrado en los mega hospitales insulares y monolíticos, donde la complejidad, los altos costos y la enorme concentración de pacientes impide una atención de calidad, promoviendo en todo caso el funcionamiento de redes integradas, integrales y complementarias de salud y atención médico-sanitaria, con incremento en el número de establecimientos mucho más simples, que al abarcar mayor extensión territorial y ampliar la cobertura, se aproximen al poblador, permitiéndole a él y su familia un acceso más universal, directo, oportuno, barato y humanizado. Este modelo, que obviamente incorpora el control sistemático de la mujer embarazada y el niño sano, la consulta externa para el diagnóstico temprano de las enfermedades, el seguimiento regular de enfermedades crónicas y la atención resolutiva de patologías simples, plantea además el rescate y fortalecimiento del médico clínico de familia, elemento fundamental de vinculación entre la sociedad y los establecimientos de salud. Por tanto, la modificación del modelo sanitario que se propone tiene una profunda connotación doctrinal, económica, social y ética, porque implica verdaderos cambios estructurales en la organización sanitaria misma, más allá de medidas econométricas, ambiguas o puramente coyunturales. Ante este desafío, el factor más importante que entra en juego es transformar el pensamiento y comportamiento de los recursos humanos anclados aún en lo puramente biológico sanitarista y ahora tecnológico, que, reemplazando las capacidades humanas del clínico, nos esclaviza y atrapa en una vorágine de consumismo, al parecer irrefrenable, fuertemente propiciada por los intereses económicos y mercantiles de transnacionales globalizadas, que hacen de la enfermedad un lucrativo negocio, distrayendo perversamente los verdaderos rumbos que debiera seguir la salud universal y los recursos humanos que de ella se ocupan, para lograr, en definitiva, que la atención primaria de salud deje de ser tan débil o simplemente enunciativa en foros y conferencias y se convierta en un mandato ético con compromisos y responsabilidades claras. Si lo dicho se cumpliera, estaríamos viviendo el nuevo paradigma del que habla Fritjof Capra, con una visión integradora y sistémica de la salud, y que, asumiendo la autotransformación de cada uno de sus componentes, se revitaliza, recicla y autogenera de manera permanente. Este trabajo no estaría completo si, además de manifestar inquietud por la institucionalización y mejoramiento de la salud, como he pretendido mostrar, no concretáramos como Comité Nacional de Bioética de Bolivia las siguientes propuestas. 1. Fortalecer políticamente el sector salud, ejerciendo mayor protagonismo en el contexto estatal y social, con potenciamiento y movilización efectiva del ciudadano en aras a la reivindicación plena de su derecho a la salud. Los políticos tienen que entender, y los gobiernos en general tienen que entender, que la salud es la primera razón de Estado. En segundo lugar, cambiar radicalmente la formación y capacitación de los recursos humanos en salud, con una orientación de recuperación clínica y mayor contenido social, ético y humanístico. Un tercer punto, dejar de propiciar o auspiciar el centralismo de la atención médico-sanitaria con crecimiento y proliferación de hospitales, como lo vienen haciendo varias agencias de financiamiento internacional. Es un gran negocio construir hospitales y equiparlos. En cuarto lugar, cambiar la visión puramente sectorialista y localista de la salud, promoviendo la construcción de sistemas integrales de desarrollo, especialmente en el área rural. Y en quinto lugar, racionalizar y regular el uso y consumo tecnológico. Por último, y coincidiendo con el ex subdirector general de la Organización Mundial de la Salud, David Tejada Rivero, comillas, él decía, tal vez sea necesario convocar a una Alma Ata II para relanzar, sin distorsiones, los conceptos que dieron origen a esa conferencia en 1978. Por supuesto, con las debidas actualizaciones y profundizaciones de los grandes cambios mundiales y de las experiencias de estos casi 35 años transcurridos. Muchas gracias.
Thank you very much, Dr. Luna. We are now having the presentation. Dr. Daniel Piedra from Cuba is coming over.
Los primeros atisbos de lo que llegaría a ser el llamado sector de salud en Cuba surgieron del certero y valiente diagnóstico con el que Fidel Castro denunció las múltiples injusticias a las que se veía sometido el país en el conocido alegato de defensa La historia me absolverá, en 1953. Cuando en 1959 triunfa la revolución con la toma del poder del Estado, la situación en la que nos encontrábamos los cubanos no había mejorado respecto a la de 1953. De los escasos 6.000 médicos con que contaba el país, la mayoría se encontraban radicados en La Habana, sede también de la única facultad de medicina con que se contaba entonces, y en las capitales de provincia. Eran pocos los habitantes de las montañas y zonas rurales del país que habían visto jamás un médico. Los indicadores de salud no podían ser más desastrosos. Esta situación amenazó con conducir al caos cuando la ya escasa masa de médicos se vio reducida súbitamente a la mitad debido al éxodo inducido por la potencia que se erigió en enemiga a muerte del Estado Revolucionario Cubano. Muchos profesores de medicina de nuestra única facultad siguieron el mismo camino. La ley fundamental de aquel naciente Estado, sin embargo, insistió en consagrar el derecho de los cubanos a la atención y protección de su salud. Pronto habría una ley de salud pública, la Ley 41, que haría que se fueran estableciendo las bases de lo que sería un sistema nacional de salud pública. Los principios plasmados en este sistema, ustedes ven en la diapositiva, resultan novedosos y singulares en la medida en que son los que animan y conforman toda su actividad, plasmándose en resultados indisputables. Durante la década de 1980 quedó consagrada la excelencia del sistema con el completamiento de algunos de sus programas básicos, así como con la dotación de la necesaria infraestructura que garantizaría su funcionamiento. A continuación, pido que se me permita simplemente mostrar las diapositivas, demasiado numerosas que traigo, que ilustran los resultados obtenidos en nuestro sistema de salud hasta que consuma el tiempo de que disponemos, que no es mucho. Muchas gracias por su atención y vayan mirando lo que les tengo que mostrar. La expectativa de vida en nacer en Cuba, en el momento actual, los indicadores de crecimiento poblacional, la fecundidad, la tasa global de fecundidad, la tasa de crecimiento de población extremadamente baja, las principales causas de muerte en Cuba, que este perfil se parece muchísimo al de cualquier país desarrollado, el programa materno-infantil al que se refería como una esperanza mi colega Javier Luna Orozco, que en Cuba está plenamente en funcionamiento desde hace años, la mortalidad preescolar y escolar, que son realmente envidiables, quisiéramos que fuera cero, ¿no? Y es a lo que enfilamos nuestros esfuerzos. Y veamos que los indicadores son el resultado de estas medidas que se tomaron en las fechas que indican las diapositivas. La nutrición, el problema de la nutrición, que es una prioridad dentro del Sistema Nacional de Salud. La estadística de desnutrición, de la cual estamos también orgullosos, por cuanto no somos un país rico, no somos un país con gran abundancia de alimentos, ni mucho menos, pero sin embargo miren lo que es manejar adecuadamente lo poco que se tiene, los resultados que da. El programa de inmunización, ejemplar también de nuestro país. Las enfermedades transmisibles, que muchas de ellas se han ido eliminando. La mortalidad por enfermedades infecciosas y parasitarias. La prevalencia de VIH-Sida. La industria biotecnológica y farmacológica de que dispone nuestro país en este momento. El Programa Nacional de Control del Cáncer, también, con importantes contribuciones del potencial científico cubano, la atención a la discapacidad, la Red Nacional de Genética Médica, la matrícula en las universidades, etcétera. Sí. Bueno, eso es todo lo que tenía que decirle, colegas. Muchas gracias por su atención.
Muchas gracias. Thank you very much, Dr. Piedra. Our next presentation is Professor Anoja Fernando from Sri Lanka.
Ladies and gentlemen, I'm afraid my presentation does not quite support the theme for this morning because national bioethics committees have not played a role in Sri Lanka's health achievements. When one looks at global maps related to health or disease, one finds that Sri Lanka is often depicted in a different color to that of its immediate neighbors. Here, for example, it is the same color as Australia, New Zealand, Europe, Russia, Canada, Brazil, Argentina, indicating that Sri Lanka is rather different to its immediate neighbors, at least in the field of health and disease. I will speak briefly of the 3 best health achievements in the past century: universal health coverage, improvements in maternal and child health, and gains in vaccine preventable and other communicable diseases. This slide shows how the infant mortality rate came down from 140, that's a line in blue, to 10 per 1,000 live births, and the neonatal mortality rate from 75 to 8, that's the red line, starting from the time Sri Lanka, then known as Ceylon, gained independence from Britain in 1948. Sri Lanka has the lowest maternal mortality rate in Southeast Asia. The next 2 slides show the steep decline in maternal mortality rates from about 1,500 deaths at the time of independence in 1948 to a low of 31 deaths per 100,000 in 2010. The expanded program of immunization carried out comprehensively with the help of UNICEF has been a great success. Even during the 30-year war with the Tiger terrorists, immunization of children in the north and east of the country was carried out without a break after arranging a temporary ceasefire between the combatants. The last case of polio was in 1993, but we had to wait until the entire Southeast Asian region had eradicated polio to be certified polio-free by the WHO, and that happened early this year when India finally eradicated polio. Most of the other childhood communicable diseases have been almost eliminated or greatly reduced. Since gaining independence from Britain in 1948, successive democratically elected governments in Sri Lanka have followed socialist policies in providing free health care and free education, including university education, to all its citizens. From 1950 to 1970, the health service was based on the primary health care model underpinned by equity and social justice and included universal coverage. This was before Alma Ata, with its Health for All PHC model for developing countries. Female literacy and the general high status of women in Sri Lanka were important factors contributing to the improvements in maternal and child health. In 2010, Sri Lanka was ranked 16th in the world, 1/6, for gender equality in the Global Gender Gap Index, ahead of many developed countries. And please don't forget that the first female head of government in the world was a Sri Lankan, Sirimavo Bandaranaike. Another important factor contributing towards universal health coverage was the Sri Lanka National Pharmaceutical Policy enunciated by the late Professor Senaka Bibile in the early 1970s, ensuring good quality drugs at the lowest possible price and in the minimum numbers necessary for treating diseases. In other words, the essential medicines concept. This was a landmark document and would influence the WHO to later develop its action program on essential drugs for developing countries. Professor Bibile was called the Sri Lankan who challenged the global giants, meaning big pharma or the transnational pharmaceutical companies. That was a difficult time for Sri Lanka when a Western country issued threats of sanctions and aid cuts if the policy was not reversed. I believe a similar drug policy was also formulated in Chile about the same time. So what is the paradox we are speaking of? This is the Millennium Preston curve. Actually, there's a small mistake in one of the axes. The scale should be on a logarithmic scale, not an arithmetic scale as indicated here. It shows the empirical relation between life expectancy at birth and the real per capita income of a country. People born in rich countries, on average, can expect to live longer than those born in poorer countries. At low levels of income, an increase of income is associated with large gains in life expectancy. However, at high income levels, the curve flattens out, and further increases in income are not associated with significant increases in life expectancy. But some countries do not follow this general pattern. Sri Lanka, with its per capita income of around 2,000, would be expected to have a life expectancy in the 60s, but it is up there in the 70s with other similar countries like Cuba, Chile, Costa Rica, and China. If we were still called Ceylon, we could call it the 5 Cs. This slide shows Sri Lanka having the best neonatal mortality rate in 2004 among the 11 zero countries. This table gives some statistics and indices of a few selected countries, such as population, per capita income, life expectancy, infant mortality rate. There's another small mistake there. For China, the population should be 1,380, the zero is missing. The two health indices of the midget Sri Lanka compares quite well with those of the giant US, 20 times richer. In this table, we see 5 countries with healthy life expectancies. In the first column, we have the real per capita income. In the second, the real life expectancy at birth. In the third, the per capita equivalent of the real life expectancy. And in the fourth, the life expectancy equivalent of the real per capita income. Let me explain by taking Sri Lanka. The real per capita income is $2,140. The real life expectancy is 75.3 years. For a life expectancy of 75.3 years, the predicted income would be $9,890 US. That is 5 times higher than the real income. For a per capita GDP of 2,140, the predicted life expectancy would be 61.2 years. But the real life expectancy is 75.3 years. All 5 countries in this table have higher real life expectancies than those predicted according to their real incomes. For example, Australia, 2 years more, Chile, 6 years more, China, 9 years more, Japan, about 5 years more, and Sri Lanka, 14 years more. This is the paradox. It's almost a little health miracle. This phenomenon, good health at low cost, has attracted the attention and interest of others for a long time. Let me give a few examples. At a conference sponsored by the Rockefeller Foundation in 1985, 3 countries and 1 state in India, Kerala, were studied. About Sri Lanka, the factors identified include expansive primary healthcare system provided free to the whole population, pro-equity strategies across several social sectors, and something that is not there in the slide, a range of actions facilitated by the country's political system and the culture of civil society participation. At another conference, they identified that the system had developed over a long period, that it was endogenous and not very aid dependent. And they also recommended that the WHO and international donors should support pilot projects similar to Sri Lanka's approach in other developing countries. Sri Lanka is grateful to all the organizations and donor agencies who supported their health initiatives over the years, especially the WHO and UNICEF. And we also appreciate the recognition given by WHO for our achievements. What then were the lessons learned by Sri Lanka? What were the factors, positive factors responsible for these achievements? The three most important are political commitment of successive governments since independence in 1948, the importance paid to public health measures in the national agenda, and addressing the social determinants of health. And there are very many others. Time does not permit me to deal with these. What of the future? We should not remain complacent, but strive to improve more and more and face the emerging challenges of high-tech medicine and the high cost of drugs. I would like to acknowledge and thank my colleague and friend, Dr. Palitha Bekon, President of the Sri Lanka Medical Association, formerly of WHO CERO, for providing me with the title of this presentation and also many of the slides. Thank you very much.
Thank you very much, Professor Fernando. Now we have the presentation of Estonia, Professor Hele Everius.
So, hello to everybody, dear colleagues, ladies and gentlemen. I have been very happy to be a part of this summit here, and exceptional thanks to the organizers, Dr. Manuel Ruiz de Chavez, who is a colleague. It has been really already, you see, it hasn't been a long time, but if you have a very interesting and good atmosphere, it seems I have been longer than one day, almost much longer here, and this is a very good mark. Thank you very much. You may ask, why such a title? I have been taking it from our seminar, what our Estonian National Ethics Council has been organizing last year. We usually have one targeted issue for every year because we are not really working full-time. It's our hobby to do the work in our Ethics Council. And it has been 1 year work to prepare the publicly open workshop seminar on this issue. We have been really having discussions with all levels, I guess, with professionals, I mean the medical doctors, nurses. Also, there are stakeholders in every big hospital and smaller ones, then the big decision makers on the level of Ministry of Social Affairs, and also the sick fund, which is giving money, allocating money for services, and of course, most important, not every time, I think even too rarely, patients are around the table to discuss the things what are really for them. And so what has been our problems and what do we see? We can't solve through the council those things, but we at least we try to make people who have responsibility to think about that, and not only think, to have activities when it is needed. And we are sure if we want to go further, constant development is necessary. Estonia is a small country, you see there. It's mentioned, and it's a really small country. Area is comparable with Netherlands, but we have 10 times less people in Estonia. Population is only 1.3 million. And taking closer the issue, I want to touch here the most important characteristics of healthcare systems, as you well know, are really access, coverage, and with which cost it is achievable, and what is the quality. Concerning Estonia, after having back our independence after 50 years, in 1991, the first thing to do, of course, amongst other important reforms, has been also to have the Health Insurance Act. And it's really, I think, very important that it has been decided to have a mandatory system of health insurance for all employers, self-employed, farmers and their dependents, pensioners, full-time students, and pregnant women. And social tax paid by the state is for registered unemployed and military servants. So that I think without coverage now, 5 to 8% of the population, this is not a bad result. I think we can be quite happy. However, what is the content of this coverage? What is inside the story? This is also very, very important, and with what our people are not happy at all. It is still long waiting times. It's even on the level of family doctors, not to speak sometimes on the specialist level. And waiting time can be really very different for different diseases. For one patient, waiting time 2 days is already making a decision. For some, it can be longer, but hopefully it's not so bad. But sometimes you have to make it very pictorial. Cost of our healthcare. So we have social tax 33%. You see it's divided between pension insurance and health insurance. And what is quite unique, our income tax is 21%. This is flat tax. You can imagine it's influencing the overall money, which is going for really to be distributed for different aims. If you look here at the health expenditure per capita, health expenditure as a share of GDP, and pharmaceutical expenditure per capita as a share of GDP, they are low. So this coverage has been obtained with quite a small money, and it's have his results also. I have to say, all other things, pharmaceuticals, equipment, has the same price as everywhere, all the buildings also, but of course, this is on the cost of salaries of medical professionals and everybody who is working in hospitals, and the cost is that now not a little number of people, medical doctors, nurses, are leaving country to have better salaries. That's the truth. So, and here you see also, if you take expenditure per capita map, Estonia is belonging to this green area. So it's lots of things to think about that. And we are thinking, it's the big discussion in country now, how to increase healthcare expenditures, because the costs are increasing every year and much. And we want to have really good, real, nowadays, medical quality for our patients, not just the coverage. And so this under discussion is also the greater role for the private sector, especially through the insurance companies. If we talk about the quality, which is so important under this coverage, so the different things we have to keep in mind: safety first, effectiveness, avoid underuse and overuse, patient-centeredness. It has been, I mean, at least I have feelings that patients have been like somewhere. Decision makers have been the most important, of course, medical professionals, but I think patient is the most important in all this system. And sometimes I very much like Professor Herzlich saying that the patient, why you are saying patient? This is not right word. Has the patient patient to everything? No. It's not the case, of course. Timeliness also, right time for every help, equity, and efficiency also. So these are different aspects we have to take into account, and of course, all healthcare access, quality, and cost, they always have been matters of societal ethical concern. And this is why we have been taking it also through our small ethical council to discuss. And we have been really getting yes to our question for our authorities. Do we have really a good quality system in our medical care? No. They had to agree with our assumption that, and that's true, we really are lacking in Estonia integrated national strategy for quality improvement in healthcare. There are few quality management tools focused on the process and outcomes. At the same time, if we think about cost, sometimes bad quality is much more costly than real good quality. And if we speak about the equity access, we have to keep in mind really good quality healthcare. And of course, we are talking, it's very easy to say that healthcare professionals and healthcare organizations have an ethical responsibility to serve the interests of patients. And patients certainly have an interest in the quality of healthcare. But what is the nature of this interest? What level of quality do patients want? What level are they entitled to? So it's the 6 aims for improvement I have already mentioned. So that altogether, access to healthcare is not privilege. It's really what person needs. And justice and utility really require responsible, intelligent, and fair-minded policies to assure access. And it's usually, it has been, it is, and it will be the ethical dilemma is how to balance the perception of autonomy, beneficence, and distributive justice. And I'm very sure values and ideals remain significant, and very importantly, remain as an action guiding, even where they cannot be fully realized in today maybe, in certain concrete circumstances, but we know what we want to achieve in the future. Because I so much like this Slovenian proverb, a healthy man has 1,000 fishes, a sick man has only one, and this is what we have to work for. And healthy person can enjoy such a big party as Estonian Song Festival, which will be held next weekend in Tallinn, where the thousands of Estonian people from very young to very old are going to song festival to sing, and the same amount of people are gathering to enjoy that. And just yesterday, we had a nice day, Midsummer Day. Thousands of fires have been in Estonia, and the people have been gathering, having dancing, and having a good time. And I think it's a very symbolic, maybe. This guy who is jumping over the fire, I think it's like we, in certain circumstances, have to jump over our problems, over our fires. I think we are doing the right thing. I wish you a nice summer. Thank you.
Thank you very much, Professor Everius. Now we have a presentation from Sweden. Dr. Lotta Eriksson, please.
Ladies and gentlemen, it's an honor and a pleasure for me to be here in Mexico and to give this presentation. First, I would like to thank the organizers, CONBIOÉTICA Mexico, the steering committee, and the WHO team for setting up such an interesting program. And I would also like to give a special thanks to Abba Saxena, Andreas Reis, Christina Heinecke for their valuable support to the working group. And also special thanks to Daphne Feinholz at the UNESCO for helping us with the questionnaire. This presentation will give a brief overview of the Swedish next role and cover questions related to universal health care coverage as one example. Other examples of recent work from Next you will find in the background paper. First, I will give a brief comment about Swedish healthcare. The Swedish health system is committed to ensuring health of all citizens. Swedish healthcare is built on the principle of generality, in contrast to the principle of selectivity, and means that all citizens, even the most wealthiest, can enjoy welfare services seen as a public social right. Regional or municipal taxes are the predominant source of funding for health. Contributions from national government are another source of funding, while patient fees covers although small percentage of costs. Sweden's current system of health finances differs substantially from voluntary insurance plans. The system covers the entire population with comprehensive benefits. Only dental care has restrictions for those over 19 years of age. The public's perception of the system remains favorable, and the commitment to the principles of equity and solidarity of universal access are quite strong. Many of the challenges confronting Swedish healthcare can also be seen in other countries, include issues of access, quality, efficiency, and funding. In Sweden, we have an ethical platform for priority setting. The platform was developed by a governmental inquiry named the Priorities Commission, including representatives from Parliament and also expert members. The Commission presented a report in 1995, and 2 years later, the Parliament endorsed a governmental bill based on the proposals from the Commission and also made changes to the Healthcare Act. So the ethical platform, the guiding principles for priority setting in Sweden is human dignity, needs and solidarity, cost effectiveness, that is subordinated to the other principles. The most important function of the principle of human dignity is to show explicitly the grounds on which priorities may not be set. The purpose with the principle is to prevent, for example, discrimination, stigmatization of human beings. The first two principles of the platform are reflected in the amendments in Section 2 in the Health and Medical Services Act. And it says first, the goal of all healthcare services is good health and healthcare on equal terms for the entire population. And second, that the person with the greatest need for healthcare shall be given priority. The Swedish Council has discussed and worked with questions related to prioritization and access to healthcare over the years, and was involved in the process when the ethical principles for priority setting was formulated in the mid-90s. In 2009, the Swedish Council gave an opinion concerning a proposal from a research institute to reformulate the ethical priority setting principles in Sweden, and also introducing the principle of individual responsibility as a way of rationing healthcare. The Swedish Council rejected the proposal from the institute and strongly rejected the proposal to include a principle concerning individual responsibility. There were several arguments, and among them it would be impossible to definitely distinguish between effects of lifestyle versus inherited factors. You can find the opinion on the Council's website. And what about the impact of the Council's opinions? Well, so far the ethical platform remains the same. And another example, last year the Council pointed out in the consultation response from a governmental inquiry concerning prices, supply and market conditions within the pharmaceutical and pharmacy area that a governmental agency deciding on drug subsidies should include other values besides cost effectiveness in their deliberations. As a result of the opinion, the Council now has an ongoing ethical debate with this agency. And a last example, last year in November, the Council organized a seminar, 2013, on ethical and health economics aspects on orphan drugs. The main question discussed was, how can we justify high cost for orphan drugs in contrast to other drugs, and can we afford it? There were participants from different governmental agencies, researchers, interest groups, organizations, and politicians from both county councils and parliaments. So this is just a few examples on how the Swedish Council works. And now I will say something about our ongoing project. It's about co-payment and out-of-pocket payments in healthcare. This project is a follow-up to the opinion on priority setting in 2009. We have a working group within the Council with both experts and political members. Co-payment is a new issue in Swedish healthcare. It has been implemented in just a few county councils, approximately 3 and 4 out of 21. The Council makes a distinction in the forthcoming report between out-of-pocket payment, is that patient pays the total cost of the healthcare services or product, and the term co-pay is used when the patient pays for part of the costs. The Council will primarily focus on co-payment in the report, and the following questions are in focus. Is there a principal difference in degree or nature between co-payment and out-of-pocket payment? What services should be covered by the publicly funded system, and what may be paid for by co-payment or out-of-pocket payments? The goal of the report is to accomplish a set of criteria, guidelines for co-payment in the public health care system. Co-payment raises the ethical conflicts between, on one hand, patients who can manage to pay, can improve the quality of care and strengthen their ability to make own decisions. And on the other, there's a risk for increasing inequalities in healthcare with larger health gaps between groups in society. Out-of-pocket payments and co-payments within the public health system could also be in conflict with the principles of needs and solidarity in the ethical platform and the fundamental values of the Swedish Healthcare Act. Can the introduction of co-payment lead to a principal change of the healthcare system from a general high standard system, the same for all, to a lower-based level system? And may it have an impact on people's willingness to contribute to a publicly funded tax-based healthcare system? Allow me to give you some examples on healthcare services and products that are being under consideration in the Council. In some regions in Sweden, the patient can choose a model outside the public health supplies and pay just for the additional cost. Is this really a problem from an ethical point of view? Well, to be able to pay to get another model out of the supplies within the base raises the ethical conflict between, on the one hand, the interest of patients to choose among several models. More patients can get access to a newer model faster, and on the other hand, the risk that the private provider of public care sells in a much more expensive device than the patient needs. And there's also concerns about possible future consequences for other areas in healthcare. Another example, cataract surgery, co-payment for advanced lenses. Another example discussed within the forthcoming report is co-payment for advanced lenses when you have a cataract surgery. Recently a few county councils gave patients the opportunity to pay extra to get a lens that will also correct the patient's vision. This example poses almost the same ethical quandary as the example before. I will just give you some of the arguments, pros and cons, discussed in the Council. Arguments pro, patients are given an opportunity to have a concomitant refraction correction when they have a cataract surgery to avoid glasses. Patient who can afford gets more choices. It gives larger patient groups the ability to get advanced lenses to reduce price. And a new market is created. Arguments con, only people with the ability to buy. The extra cost per eye is rather high. The opportunity can lead to the displacement of more urgent procedures. The procedures takes longer time than a normal cataract treatment, and you have to have surgery on both eyes. Risk of indication slippage, acceptance for co-payment in other areas in healthcare. Finally, I just give a few more examples that are discussed in the forthcoming report: assisted reproduction, psychotherapy, and to get a single room at the hospital. The report will be translated into English and will be found at our web page in late autumn. Thanks for your attention, and I would also like to thank Kjell Asplund, the chair of the Swedish Council, for helping me cutting my slides down.
Thank you very much, Dr. Eriksson. We have now some time for commentaries, questions, general discussion. If anybody have something to say, can raise the hand. Dr. Daniels.
Yes, I wanted to say that the slide that the representative from Sri Lanka showed of the increased cost the plot of life expectancy against national income on the average and average income per capita suggests that policy is much more important than wealth. And this is a point that I agree with and have used in my teaching. In fact, I was not surprised at the slide because I've used exactly the same slide myself.
Thank you, Professor Daniels. Anybody else want to share over there? I can't see the country.
It's Ireland. I have a question for both Professor Daniels and for Lotta from Sweden. It's in relation to how does the WHO report take account of rare diseases and orphan drugs? Because as you mentioned, sometimes governments come under quite a bit of pressure, both from advocacy groups, and you generally can see governments, if you like, cave in to a certain extent in provision of these treatments, because you have very articulate and well-organized advocacy groups saying, well, we need to help these people. And so it's a very difficult question around the whole question of equity. And I wonder, does your framework cater for that at all? And I know, Lotta, you also mentioned that this is a debate in Sweden, and I wonder what the thinking is around how, and is this something, for example, there could be a co-payment for, or how it's going to be dealt with? Thank you.
Professor Eriksson, first.
Thank you for your question. Orphan drugs is under discussion in Sweden. The Swedish Council has not yet dealt with the question. I mentioned the seminar we held in 2013. It's a governmental inquiry sitting, and I think they will soon give their advice. And I think it's not under discussion concerning co-payments, at least what I have seen. The discussion we had in this seminar in November, it was, well, how can we argue and can we use the present ethical platform to argue for that it can cost more? And one of the philosophers or two of the researchers think that yes, we can use the principle of solidarity and in that way accept that it can cost more for these groups. Thank you.
Professor Daniels?
Yes, this is of course a very difficult question. I'm working with some people in Canada where there is no orphan drug law, and I have a graduate student who is focused on this issue. But I think it's a very difficult question because on the one hand, intuitions suggest that fairness would not leave behind individuals who have rare conditions. On the other hand, the high cost means that some people who, if we relax the standard, then some people who have more common diseases would not be treated in favor of people with rare diseases under budget limitations. So a lot of the efforts to secure funding for orphan drugs come from the drug companies lobbying on behalf of patients. And it's the politics of this is very important. So my own view is that reasonable people can disagree about how much support and relaxation we should give for this, because there are arguments on both sides of this question that are reasonable, and so we needed a deliberative process. I don't think that there is a general consensus on the fairness question about exclusion of more high-cost drugs for rare conditions.
Christian, so from and then you.
Sorry for that, but just to make things a little bit more complicated, under the times of the so-called and hyped personalized or individualized medicine, we will get more and more orphan drugs. So how do we define it? Yeah, there are a lot of women with breast cancer. It's a really widespread problem. But if you have a lot of subpopulations with just few women having a special type of breast cancer, and just some drugs are working there, then they are orphan drugs. So that's really a huge problem, I think.
Thank you. Professor Everius?
Just a short comment. I don't think it's a huge problem. We have to find the way how to solve it. Because first, if we talk about really the orphan diseases, orphan drugs, I think if you calculate cost, anyway you are going to treat them. If you, for example, I have 3 patients with Gaucher disease. That has been long discussions to have covered. Oh, it's thanks God, not for God, but for our taxpayers. It's all these young patients have been covered with enzyme replacement treatment, and they are completely free of any need of any other treatment. Without that treatment, they could have been passing several operations and being disabled people not able to work. They all work. So this is another side of the story, and we have been usually, when we are discussing with our health resources dividers, we are explaining all this, so that I think, and for personalized approach, you all know that now when we don't have personalized approach, more than 60% of treatment is ineffective. This is a huge cost, so that if, I don't think, I'm very optimistic. I think this is a way to go. Right treatment to right person, and we all are individuals. So that I'm very optimistic. Thank you.
Thank you. Dr. Mohamed.
Thank you. I would like to ask Dr. Javier Ernesto Luna from Bolivia. We had a debate in Tunisia. We wrote just a new constitution, and the Article 38 is offering health for everybody. We said health is a human right. And we said we have a debate, should we say for Tunisian or for all the humanity? And we wrote, health is a human right for everybody. And now we are receiving a lot of refugees from all the regions, and it's really a problem because it costs a lot, because perhaps we have a better health system, I think, from other countries near us. So what do you think by this, good intention, but it reduces for the Tunisian what they put in, in the common, the common social or health paquet, I would say.
Professor.
Yo considero que cada país tiene que trabajar intensamente en hacer efectivo el derecho incuestionable a la salud, porque varias constituciones de varios países, por lo que sé, no hablan de un derecho fundamental, hablan más de un deber ético, el otorgar servicios de salud. Entonces, cuando la población o el individuo reclama por su salud, si no tiene el respaldo legal que esté consignado en la Constitución Política del Estado o esté consignado en la Ley General de Salud, es difícil el poder reivindicar esa necesidad de salud que tiene la población. Entonces, yo creo que es muy importante el trabajar en pro del derecho a la salud como un derecho perfecto, ya lo decía yo en mi exposición, ¿no? O sea, un derecho fundamental, incuestionable, que sea la base, digamos, para obligar, entre comillas, al Estado, al gobierno, a trabajar en procura de la salud. Yo creo que esto no se está dando en muchas realidades como la nuestra en Bolivia. Hay un artículo en la Constitución Política del Estado en Bolivia que establece claramente que la salud debe ser privilegiada económicamente. Y sin embargo esto no se cumple. Se hacen gastos dispendiosos en muchas otras cosas y la salud sigue siendo postergada. Entonces, este es un tema de profunda preocupación, por lo menos para nosotros, porque aparte de tener desorganización sanitaria, no se cumplen ni siquiera la Constitución Política del Estado. Entonces, tenemos que trabajar mucho en ello, entendiendo que las realidades son absolutamente distintas entre países.
Thank you, Dr. Luna. We are on time. Two more interventions, and then we are finishing because we are on time. Okay. First here.
Thank you very much. I would like to share our experience from Kenya. We have in our constitution now that we should have health for all by the year 2030. And we have started introducing free maternity care in the country. And also we have national health insurance policy, which is now being implemented in a big way. However, we run into a lot of problems. When we started the free maternity care, we were not prepared with the infrastructure, and the various units were overwhelmed with the number of patients. But we did notice that there is a drastic reduction in maternal mortality since we introduced the free maternity care. The other problem we have is like we have our neighbors, some of them do flood into Kenya because of this free maternity care. They disguise themselves as Kenyans. So in the bordering hospitals, we do have problems with a lot of people accessing free care because our neighbors don't have that kind of policy. I agree with the professor that we need to, I forget the name, like you were giving the example of Sri Lanka, that they did very well because of change in policy. However, there are financial implications. When you do change policy, you do need extra funding for that, and we need to be prepared. In Kenya, we also have an additional problem of refugee population, like the others mentioned, and that is a real burden to us. Some of the refugees also filter into the cities from the refugee camps to access medical care. So we are overwhelmed with the number of patients who are accessing that. So it is, although it's a good thing to have care, free care for all the people, but to implement this, it takes a lot of time and a lot of organization. I think we really, it's ethically speaking, we do need to provide them with these services. In my country, a lot of patients are dying of renal problems because they cannot access free dialysis services or such treatment. So now our national health insurance policy has sort of given a halfway thing. They pay half the cost for the dialysis, which has made a big difference also. Many more people are able to access those facilities. Thank you very much.
Thanks to you, and the lady here.
Thank you. I'm Farhat Muazzam from Pakistan. I just have a very quick question for Dr. Anoja. Sri Lanka and Pakistan were neighbors, you referred to that. And what has always struck me is about all of us in Pakistan, about Sri Lanka, your socio-political setup, militancy and other things, is not very far from that of Pakistan. Similarly, as you pointed out, the national bioethics committees per se, although we're sitting in a summit for them, like Pakistan, I do not believe they've been very effective. My question to you is, in Sri Lanka, what were the pushing powers? Was it the healthcare professionals? Was it your society that has been able to shift and improve matters as compared to essentially all your neighbors? So I wonder if you could say anything about that.
Professor Fernando?
Yes, thank you, Farhat. I think I'd just like to make a small correction regarding what the member from Kenya said. We did not change the policy at any stage, Sri Lanka. It was the policy right from the very beginning, from the time we got independence from the British. And actually, Farhat, I believe, and most people in Sri Lanka believe, that it is the cultural attitudes as well as the political commitment of the Sri Lankans right from the beginning that led to this sort of policy from the time of, actually even before independence, all of us were under the British, as you are aware. Now we gained independence in 1948, but in 1931, the British, for some reason, they had what we call the Donamo reforms, the new constitution called the Donamo Constitution, under which there was an establishment of a state assembly, and at the same time they introduced universal adult franchise to Sri Lanka in 1931, which was just a very few years after Great Britain had universal adult franchise. We were one of the first countries in the Asian region to get that. So that was a great thing for us. Everybody had the vote, including all the Sri Lankans. And with the Donamo reforms, the state assembly, we could elect, of course, a limited number of our own people, of our own Sri Lankans, to the state assembly. And the British, the imperial government of Britain, gave the responsibility for agriculture, education, and health to this state assembly. So the Sri Lankans themselves agitated. They made radical demands for equity in healthcare, in agricultural practice, nutrition, and education. They agitated, and the British were forced to start providing health services. At the time of the British, they paid a lot of attention to the health services in the capital city and also in the estate population, because that was their economy. Their economy, the tea plantations were based on the labor in this estate. And they were looked after, but the vast majority of the rural population, the common people in Sri Lanka, had a very poor deal as far as health, nutrition, and so this was the start. Our own people, with the universal adult franchise and the Donamo reforms, had the chance to start agitating and demanding from the British, and they did give in a little. But with independence, I think it's a cultural thing, and it would take too long for me to give the real reason, but people who are interested in the history of medicine would know that some of the earliest hospitals are found in Sri Lanka and Myanmar, Burma, and these are based on the policies of Emperor Asoka of India.
Okay, we're closing now. Thanks for all the speakers.